Gaddis Stowe, who I know as Gaddis, is Farm D, who we were just talking. I've known since I was a little fellow with hair that was brown, way back when. Who now has gone on to big things in the industry, and it's come today to again talk to us about diabetes and Sglt inhibitors and everything else, as it becomes much more of a cardiac and a heart failure issue. Not that it hasn't always been one that we're considering. So thanks, Wendy, for coming. And
thank you. Thanks for the opportunity to be here. It's great to see you all. And just a couple of things. There's a pad of paper on the back, so just a signing sheet for me. That's helpful for me. And so as Dr. Russell said, I'm Wendy Gaddis-Stowe. I'm medical science liaison with Genesis Scientific Affairs. And I support the clinical trial data and scientific information for cardiovascular metabolism. So that covers panagliflozin, which we're going to talk about today, as well as rivaroxaban and Sglt. And I also left some cards back there by the sign-in sheet. So at any time, if you have clinical questions that come up in your practice, you need kind of more information about the clinical trial data, or just any kind of general clinical questions about either of those, feel free to reach out by the phone or email, and I'll be happy to answer those questions. But for the purpose of today, we're really going to be talking about Invokana and type 2 diabetes. And as Dr. Russell said, when I met with him, we were chatting about this whole intersection between cardiology and diabetes and how the field has really evolved so that now you all are making decisions and taking on therapies that might have been managed by primary care or endocrinologists or other entities. And so really trying to figure out what clinical data can we look at to help you guide those types of decisions. And so Dr. Russell mentioned kind of 3 specific subpopulations that we have interest in. So patients with existing cardiovascular disease, heart failure patients, of course, and then patients with renal disease. And so what I'm going to do is give you an overview of the Canvas program. And Canvas is the pivotal trial that really led to the indication of cardiovascular outcomes for panagliflozin. But to get us all on the same page with the overall trial, and then we'll look at each one of those 3 subsets, look and see what the data say about efficacy in those. Going to give you some sense and help inform your clinical decision making. And then at the end, we'll kind of talk about some just practical applications, and we should have plenty of time for questions. So I won't spend too much time on this. Obviously, you all are very well familiar with this intersection between type 2 diabetes and cardiovascular disease, and just the increased risk that type 2 diabetes causes, increasing the risk of MI, stroke, and cardiovascular death. And obviously, these are things that you all every day are trying to prevent when you're taking care of your patients. And so, what kind of data, what kind of therapies do we have that help reduce that risk? Again, just to set everybody on the same page, I want to kind of go over what the indications are for Invokana, because some of what we'll talk about falls outside of this, and I'll try to be pretty clear when we're talking about things that are reflected in the current label and as well as things that are not. But obviously, the first indication for Invokana was to improve glycemic control in adults with type 2 diabetes. That's not what we're really going to be talking about here today. But more recently, last October, Invokana received an indication to reduce the risk of major adverse cardiovascular events. So that includes cardiovascular death, MI, and stroke in patients with type 2 diabetes and established cardiovascular disease. And so that's really what we're going to be focusing on today. It's not, just want to point out, it's not indicated in type 1 diabetes or for the treatment of DKA. And then also wanted to just recognize the boxed information that we have with the risk of lower limb amputation. And that was a signal that came out of Canvas, and we'll talk about that a little bit more as we go through the talk, in terms of where the locations were and what type of precipitating factors to be aware of. But just to kind of move on with the Canvas program, so for those of you who might not be familiar, this was an integrated program with 2 studies which were designed really identically with the plan to integrate them into one analysis. And this is really consistent with, if you might remember, the FDA changed back in 2008 the way that new drugs for diabetes had to be reviewed and demonstrate cardiovascular safety. And so this study was designed to meet those requirements. And it included over 10,000 patients. They all had type 2 diabetes, obviously. The hemoglobin A1C criteria you can see greater than or equal to 7 to less than or equal to 10. They all had eGFRs greater than or equal to 30. And then in terms of their cardiovascular risk, so to get into the trial, they either had to have some known history of prior cardiovascular disease, so a past MI, coronary disease, cerebrovascular disease, peripheral vascular disease, or they had to have, they had to be at least 50 years of age and have more than 2 or more risk factors for cardiovascular disease. And that could have included a long duration of diabetes, uncontrolled hypertension, smoking, those types of things. The primary endpoint of the overall Canvas program was this composite endpoint of cardiovascular death, non-fatal MI or stroke. Secondary endpoints were like all-cause mortality, cardiovascular death, and then there were a whole host of other exploratory endpoints looking at cardiovascular death and heart failure hospitalization, which we're going to talk about a little bit, and also some biomarker-related endpoints looking at renal safety, albuminuria, and then some renal composite endpoints. Just to give you a sense for what type of patients you're looking at here, the mean age was 63. Patients that had diabetes for a pretty prolonged period of time, about 14 years. As you can see there, about 15% of patients in the population had heart failure, and about 66% had known cardiovascular disease. The other third had just the risk factors for cardiovascular disease. So this is the primary result of the overall trial, the primary Mace outcome, showing a hazard ratio of 0.86 for the overall outcome, and that met the threshold for non-inferiority and superiority. And I won't get into all that because that kind of gets back to the FDA guidance, but it met both of those thresholds. And if there are any questions about that, I'm happy to kind of go through some of that. Now, one thing when my background is some clinical practice, but a lot of clinical trials too, and I always, when I look at a composite outcome, I always want to look at what the individual components do. And so what we're looking for here is consistency across the individual components. As you might know, when you do a big trial and you use a composite endpoint, you do that because you're trying to get a bigger event rate. You can do that with patients. So you don't expect any single endpoint to be appropriately powered, but you power it on the larger endpoint. But you still want to see two things. One is that the treatment effect is consistent across endpoints, and the other that the treatment effect isn't driven by one component. And so that's what we saw here. Very consistent treatment effect across cardiovascular death, non-fatal MI, and non-fatal stroke. And then if you look down to the exploratory endpoint of cardiovascular death or heart failure hospitalization, that was about a 22% reduction in that endpoint. And then all-cause mortality, again, not powered to look at this, but the hazard ratio was 0.87. So a 13% reduction in all-cause mortality, not significant, but certainly no evidence that there are off-target effects that offset the benefit on the primary Mace outcome. And that's really kind of what you're looking at with all-cause mortality in these types of trials. Safety, of course, is really important, and so just to kind of point out a few things here. Some of the adverse effects that were observed were known effects with Sglt2 inhibitors, the general mycotic infections that we've seen, all amputations I'll come back to in a minute, and then there was also 15 adjudicated fractures seen in the mechanical closing arm compared to 12 in the placebo, but that was a significant effect of the hazard ratio of 1.26. You can see that in the back. So obviously, understanding the amputation signal was really important, and so several analyses were done to kind of look at this. One of the things I want to point out is the event rate. So these are event rates per 1,000 patient years. So there were 6.3 amputations per 1,000 patients treated for 1 year in the mechanical closing arm compared to 3.4. So overall, a low event rate of this event, but obviously an imbalance between the two groups. The majority of these, 71%, were at the toe or the transmitted tarsal, so what was classified as minor amputations, and then major amputations made up the remainder. And again, you look at the event rates in each one of these subsections, and they're very low, but an imbalance by treatment group regardless of how you categorize it. And we went on to look at to say, okay, well, how do we explain this? What were the predictors? What were the causes? And so this was the multivariate analysis that took all the baseline risk factors and put it into a model to try to figure out what would predict amputation signal. And so by far the strongest predictor was prior amputation, so patients that had an amputation at baseline. Other things that came in, peripheral vascular disease, neuropathy. Mechanical closing treatment did come in as an independent predictor in the model with a hazard ratio of 1.8. And then the other thing that we learned by looking at the data were that over 90% of the patients in either group, whether you were in the mechanical group or the placebo group, had some other comorbidity or precipitating factor that could have contributed to an amputation. So they either had an ongoing infection, gangrene, some wound, acute ischemia, those types of things. So this kind of information really helps understand sort of which patients were at greatest risk. So that's the overview. So now I'm going to move into the first group that Dr. Russell was interested in, and that is the patients with existing cardiovascular disease. So if you might remember from the initial slide, we said that 66% of the population had known cardiovascular disease. And so I show these just to kind of show you what types of cardiovascular disease they had. So you can kind of consider how this fits into the patients you see in practice. So about a little over 40% had prior MI. Over half had had a prior revascularization. Just under 20% had a history of stroke. And just less than 10% or so had a history of peripheral revascularization. So those are the kinds of things that patients came in with who were in that secondary prevention cohort. So this slide is a little bit complex, so I want to spend a bit of time with it, plus I know it's probably really small back there. So within each of these rows, the first line is the secondary prevention population, so those are the people that had known cardiovascular disease. The middle line is the patients that were primary prevention, so those are just the risk factors. And then the third row is the overall population. And so if you look at the treatment effect over here, anyway, so if you look up the hazard ratio for the secondary prevention population for the primary composite placebo death and non-stroke was 0.82 for the secondary prevention population, so about an 18% reduction in that endpoint. If you look down to the primary prevention population, you see a hazard ratio that seems kind of neutral at a hazard ratio of 0.98. So you can see that the magnitude of the treatment effect appears to be most pronounced in the secondary prevention population. But the p-value for interaction was not significant, so that means that there's no statistical difference between the treatment effect between the secondary prevention and the primary prevention population. But still, you can see the magnitude of effect is more pronounced there. The other thing that's really important to interpreting this is looking at the baseline risk of the population. So a good way to always, when you're looking at any clinical trial, to understand how at risk your population is look at your placebo event rate. So you see the placebo event rate of 41.3 in the secondary prevention population versus 15.5 in the primary prevention. So they were a much lower risk population. So really to see a benefit there, you would have had to do a lot larger set of patients and follow them for longer time. So we're not, really sure what the signal might be there, but this data just shows that the magnitude of benefit is greatest in the secondary prevention population, and that's a consistent thing that you see across all these endpoints. That is also consistent with the current labeling, as you might remember. This is indicated to reduce MACE in the patients with established cardiovascular disease. So moving on to the next subset, which is of interest, the heart failure subset. And as Dr. Russell mentioned, there's been a lot of interest in Sglt2 inhibitors and heart failure, and how all these things interact, intersection between heart failure and chronic kidney disease, which we're going to talk about next as well. So you remember I said that 14% of the population at baseline had heart failure. There are some caveats to this. There weren't requirements for ejection fraction. These patients didn't undergo routine echoes. There were no biomarker criteria for heart failure. So this was basically the investigators, checking a box on the CRF that they had heart failure at baseline. So there's that limitation. We also remember that patients with New York Heart Association Class 4 heart failure were excluded from campus, so they're not represented here. And only about 25% of the patients at baseline who in the heart failure cohort were on loop diuretics. So it kind of tells you what type of patient population would be more of a chronic stable, lower symptom burden of heart failure. But that's the population that we're going to look at. This is the overall Kaplan-Meier curve for the whole population, not just the heart failure that I showed you earlier. So again, a 22% reduction in the risk of cardiovascular death plus heart failure hospitalization. The one thing I think is interesting with this curve and what you see in a lot of these heart failure analyses is that the curves start separating really early. Whereas if you look at like the Mace endpoint, they tend to separate later. And it's probably just suggests that there's like a volume effect in some of the diuretic or volume depletion type effects with Sglt2 inhibitors could be driving that outcome. So these are the data looking specifically at the history of heart failure. I know it's small, but if you look at the hazard ratio, so in the subset of patients that had a history of heart failure baseline, their hazard ratio was 0.61. So so about a 39% reduction in that cardiovascular death plus heart failure hospitalization endpoint. When you look at the patients who did not have a history of heart failure, their hazard ratio was 0.87. So they still benefited, but the magnitude of the benefit appeared to be lower. Now this p-value for interaction was significant, so suggesting that there could be some difference in the treatment effect between whether you had a heart failure at baseline and whether you didn't. But again, this is like a subgroup of a subgroup of a subgroup, so I'd be very cautious like in drawing too many conclusions from that p-value, but it is a signal that's really worth exploring more and more trials, and as more studies are done, I think this will become a little bit clearer. The other thing I wanted to point out on this is that I mentioned there's some limitations in how these patients were classified as heart failure. But if you look at the placebo event rates, the placebo event rate in the history of heart failure group was 56.8 versus 15.2. So there was something about what the physician recorded at baseline that had some kind of prognostic meaning. Even if it might not have been a completely precise definition of heart failure, it probably was meaningful. There's also, before moving on, another analysis that just was published early in March, and I think it was in Circulation, looking at HFpEF versus HFrEF and the canagliflozin effect there. And again, it's from the same Canvas data set, so they're the same limitations about patient identification. And they didn't have EF at baseline, so they looked at the time of the first hospitalization, what was their EF. So there's obviously a lot of limitations to looking at the data that way. But basically what the results were, and I don't have the slides on this because the data were too new, but there seemed to be a greater treatment effect possibly in the HFrEF group than in the HFpEF. But when there were also some unknown EFs, and so when you lump them in the HFpEF group, it's significant. So it's really unclear exactly how to interpret that. But just additional data to kind of think about how these drugs might play a role in patients with heart failure in the future. Now, moving on to the renal, I'm going to spend a little bit of time explaining this to you because you might remember when Sglt2 inhibitors came out, there was this initial decline that we saw in renal function and people were concerned about renal injury. So it is something that we see. You can see the blue line here is the canagliflozin line. You do see this initial 4 to 6 millimeter per minute drop in EGFR. And the best analogy we have is to ACE inhibitors. So you might remember that when you give somebody an ACE inhibitor, it blocks the renin-angiotensin system and causes dilation of the efferent arteriole. That decreases your intraglomerular pressure and will cause an initial drop in EGFR, but is protective over time. So a similar thing happens, but on the other end of the spectrum for Sglt2 inhibitors. Through some different signaling that takes place through the macula densa, it actually causes constriction of the afferent arteriole. So the other side, which also decreases intraglomerular pressure, which is why you see this initial drop in EGFR. But what you also see is kind of this stabilization over time, whereas in the placebo group, it's not as if placebo is causing a decrease in EGFR, but it's just the natural history of kidney decline in patients with type 2 diabetes. So that was kind of some of the interesting data that was seen early on with the Sglt2 inhibitors. And then also it's pretty apparent that it's really a renal hemodynamic effect because on the other side of the slide, the blue line, when you stop the drug, the EGFR goes back. So it's really a hemodynamic effect of the drug. So you might remember that I said that EGFR less than 30 was excluded in Canvas, so we don't have a lot of patients with that level of kidney function in this analysis. And I'll also actually remind you that currently, according to the current label, canagliflozin is contraindicated in patients with EGFR less than 30, and that's largely because the glycemic effect is attenuated at lower levels of kidney function. And so just kind of want to remind everybody of that. But, so the majority of patients in Canvas had relatively preserved kidney function. There were only about 20% or so that had EGFR less than 60. And most had normal albuminuria with about a third or so with either macro or micro albuminuria. This is the effect on the Mace endpoint, so it really seemed to be consistent across all levels of EGFR. The Mace effect was preserved. You didn't see a loss in the cardiovascular outcome benefit across these levels of EGFR. Just for the sake of time, I didn't put these slides in there, but there were a lot of, as you might remember, I showed exploratory analysis looking at changes in albumin and all these renal different composite endpoints looking at renal protection from Canvas, and all of those were in favor of canagliflozin. But the known renal effects of SGLT2 inhibitors led to the design of the Credence trial, and the study was really designed at the same time really Canvas and kind of in that early period. And this was a study that's specifically done in the patient population with type 2 diabetes and chronic kidney disease. So this makes it unique from Canvas, which I just showed you, which had some patients with renal impairment, but it wasn't a dedicated renal trial, and this is a dedicated renal trial. These data were just presented and published in early April, so they're still very new. None of the information that Credence reflects really reflects in the current labeling, so just wanted to put that out there. But to be included in this study, included type 2 diabetes, the hemoglobin A1Cs between 6.5 and 12. They all had to have EGFR between 30 and 90. And the study was designed to achieve a 60% of patients to have that EGFR less than 60. So it was really designed to have that group of moderately renal impaired patients. UACR had to be between 300 to 5,000, and importantly, they all had to be on stable doses of maximum Mace inhibitors and ARBs, because we know that is the standard of care to reduce progression of kidney disease and type 2 diabetes. And they achieved 99.9% of patients were on these drugs, so it really was truly on top of standard care. Patients with non-diabetic causes for their kidney disease were excluded. Class 4 heart failure was excluded. Patients with a history of diabetic ketoacidosis were excluded. And they were randomized to 100 milligrams of canagliflozin or placebo. The primary endpoint was this composite of end-stage kidney disease, and that had a couple of components to it. It was progression to renal replacement therapy, renal transplant, or a sustained EGFR less than 15 for more than a month. Doubling of serum creatinine that also had to be maintained for more than a month. Renal or cardiovascular death. And cardiovascular death was included here because we know that that is really the primary mode of death of this patient population. And then there were a whole host of other secondary endpoints. So these were all designed to be tested hierarchically. So it had the power to test each one of these endpoints, and then once one did not reach significance, they stopped looking at it formally. The cardiovascular death for or hospitalization for heart failure, Mace, and some other endpoints there. So just to kind of give you a sense for where Credence falls compared to Canvas. So Canvas is over here at the C in the green box. So again, relatively preserved kidney function and low albuminuria, whereas Credence, the mean EGFR in the study was 56, and the UACR was just under 1,000. So truly a renal population. Just to again give you some sense for the type of patients that were enrolled, you got 63, mean age was 63. Again, a slightly longer duration of diabetes here, 16 years, it was 14 in Canvas. 15% had heart failure, and 50% had known cardiovascular disease. This just, I already told you what the mean EGFR and UACR was, but just to kind of show you that they did indeed achieve the 60% of patients with the EGFR less than 60, and the majority of patients had UACR between 300 and 3,000. This is the primary outcome of the study. So you see the hazard ratio of 0.7, so a 30% reduction in this end-stage kidney disease, doubling of serum creatinine, renal or cardiovascular death. That was highly statistically significant. And then this is the individual components, and again, the same thing, you're looking for consistency of treatment effect here, and also that one component didn't drive the overall endpoint. And so you see a pretty similar reduction in the doubling of serum creatinine, the end-stage kidney disease by both definitions. Renal death, the confidence interval was really wide there. There were only 2 renal deaths in the whole study. But cardiovascular death, as you can see, has a ratio of 0.78. The first secondary endpoint that was looked at is the cardiovascular death or heart failure hospitalization. This was again a pre-specified endpoint, a 31% reduction in that endpoint, 20% reduction in Mace, which is very consistent with what we saw from Canvas. And then the bottom one was basically the primary endpoint taking out cardiovascular death, and that was also significant. The next level in this hierarchy testing was the cardiovascular death alone. And you can see it was a hazard ratio of 0.78, but it didn't meet statistical significance through the p-value of 0.0502. And the way the study was designed, because of the interval looks, the p-value had to be less than 0.03 to meet statistical significance. But still, the point estimate was in the right direction. And then all-cause mortality, I believe the hazard ratio was 0.83, but the upper bound of the confidence interval was like 1.02. So no evidence that there were off-target effects that offset the benefit from the primary outcome. And then here's the safety. Obviously, there were safety, of course, were of significant interest. Again, the same things that we saw and already knew about the class. Diabetic ketoacidosis also comes out on this slide. There were 11 events in the canagliflozin arm versus 1 in the placebo arm. And this is consistent with what we've heard about this class. Looking more into those events, almost all of them, I think, except for one, was in the setting of an acute illness or when somebody wasn't having oral intake, that type of thing, or major reductions in insulin dose. But we'll come back to that in a minute. So amputation was obviously a big question in credence, and so what you can see here is there was no imbalance in the canagliflozin versus placebo arm in the credence trial. These again are event rates per 1,000 patient years, so 12.3 in the canagliflozin versus 11.2 in the placebo, but no imbalance between the two groups. The event rates here are about twice as high as what we saw in Canvas, so a higher risk population, so we should have been able to see a signal in this population. It's not really clear why there was this imbalance in Canvas and there wasn't in Credence. Credence was about 75% enrolled when the Canvas signal came out. And so there were some protocol amendments that happened. Patients had an active ulcer or gangrene, they had to hold the therapy until that episode healed. A new exclusion was put in if they'd had an amputation within the last year, they couldn't be included. But the majority of Credence had been enrolled by the time that those amendments were made, so it's unclear exactly what effect that might have had on these results. And then fracture, I mentioned that as an imbalance in the Canvas program. There was no imbalance here in Credence, and there was no imbalance in like the earlier phase 2 or phase 3 studies that were looked at. No changes in bone mineral density. So again, some of these safety data I think are interesting because they're usually based on really small numbers. And if you know, in efficacy, you never make conclusions on efficacy based on very small numbers. But of course, with safety, our first objective is do no harm. And so, there can be noise sometimes in small numbers, and it's always good to have additional data come in to help you really understand those signals. So now I just kind of want to move into, there was a lot of data to throw at you really fast, and I realize that. But just implications, what can you take from this in your practice? And I think the first question is the patient in front of you at high risk? Is this a patient that, has type 2 diabetes and, you as a cardiology practitioner can really intervene and help reduce their risk? Or, is it something that can be safe, to a waste of time? So who was the population in Canvas? We know they had type 2 diabetes for about 14 years. They were high cardiovascular risk. 60% had prior cardiovascular disease. And if you can, I know I get a lot on these placebo event rates, but if you just look at the placebo event rate, that whole population had a placebo event rate about 15% at 5 years. So it's not nothing. The patients that come in to see you with these characteristics are at risk for cardiovascular events. And so we know these diabetes drugs with evidence of cardiovascular benefit can impact those events. But we also know, and I already showed you this from the secondary prevention, is that the magnitude of the benefit is greater the higher risk your patient is. And so we know that patients with prior cardiovascular disease are at higher risk. We've shown that patients with heart failure are at higher risk, and they may have some other conditions related to their heart failure that make them respond in a stronger way, perhaps, to these agents. So again, more data are needed to really narrow down these populations, but these are kind of some data that can give you some signals of where to think about risk and how you're going to reduce it. Number needed to treat is also a question that often comes up, and so I just want to kind of put this in context. So number needed to treat is completely really based on the absolute risk of your population. So if you look at the overall Canvas population that included both the primary and secondary prevention, you need to treat 72 patients over a 3-year period of time to reduce 1 cardiovascular death, MI, or stroke in that time frame. But then if you pull out the higher risk subset, so again, those high-risk patients with pre-existing cardiovascular disease, the number needed to treat goes down because the absolute risk of the population is higher. So any time you're looking at a patient in front of you and you're trying to assess risk, that is another kind of thing to think about is the patients that tend to have the larger treatment effect may be those with underlying higher risk. Also, the other thing that affects this is the time frame you're looking at. So diabetes, cardiovascular disease are both chronic conditions. But if you look at the 5-year numbers, of course, the number needed to treat goes down the longer you treat. Now, almost equally important, if not more important than picking the right person for benefit, is avoiding therapies that could harm patients. And so, you know, we learned from the canvas what some of the risk factors for amputation were. You know, obviously patients that have had a history, certainly a recent history of amputation within the last year, you know, are really not people that are ideal candidates for the therapy. And then we know some of the other factors that kind of might have influenced that. So any patients that have active ulcers or wounds and that type of thing, you know, waiting until those issues resolve to start therapy, you know, is a prudent approach. Of course, you know, routine foot exams and patient education is very important, as you all know well. You know, so one of the questions too that comes up, you know, if let's say, you know, another practitioner is managing their whole diabetes regimen, there's some resistance sometimes to starting a new medication that could affect that, because then all of a sudden you have to adjust all these other medications for something that you did, and there could be, you know, challenges if there are multiple care providers involved. So I just kind of want to show you what to expect in terms of the effect on hemoglobin A1C. And these are data from basically all the phase 2, phase 3 studies with canagliflozin across different combination therapies and things. And you see about on average you get about a 1% change in hemoglobin A1C. We know that these drugs, the Sglt2 inhibitors in general, do not really cause a lot of hypoglycemia, so that's not really something that is a big factor. Perhaps more so if the patient's also on sulfonylurea or insulin. But there are several resources, and I don't have these as slides, but you know, the ADA, the AACE, and there are a couple of ACC type guidelines that really talk about how to think about the background therapy that a patient is already on when you're considering one of these drugs that have cardiovascular benefit, and how you might think about adjusting them or changing them, or what just kind of measures to do. And I don't have those slides, but if anybody's interested in the citations, I can help you with those. Also, this is just data from Canvas. We know that about 9% or patients in the canagliflozin arm had about a 9% lower rate use of other anti-hyperglycemic agents. So you could expect needing fewer therapies there. The one thing I did mean to mention here with the insulin, you know, one of the things that we know predicts or may contribute to DKA is large prophylactic, if you will, reductions in insulin dose. That can predispose patients to DKA. So the recommendation, the suggestion at least from the guidelines is, you know, to really individualize that type of thing. You know, start a patient on the drug and then adjust other doses as needed rather than doing it up front. And then we know that these drugs affect body weight, so anywhere between a 2, 3, 4 kilo reduction in body weight. So, you know, if patients are on concomitant diuretics or other things like that, you may need to watch the patient and kind of make some adjustments as indicated there. And then blood pressure are the other things that these drugs affect, you know, anywhere from a 4 to 7 milliliter per mercury in blood pressure. So again, you know, diuretics, ACE inhibitors, ARBs, or a whole host of other things patients may be on, and just being aware. Not to say that you need to necessarily adjust these things at the front end, but just kind of being aware that these are the effects that the drugs have. So I know there was a lot of information at one time, but I hope it was really helpful to just kind of frame the risk of the type 2 diabetes patient and how the cardiovascular risk fits in there. You know, what kind of characteristics might make you really think about when you should be considering agents with cardiovascular benefit in your patient population. So with that, I'd be happy to take questions. That was really fast.
So you mentioned the wound stuff. I saw a patient this morning who's probably 40 pounds up and oozing from her legs. Was you worried about that, or is it more kind of PVD, ulcers, and?
Yeah, I mean, you know, the data that I've seen, it sounds like it's more unhealing wounds, like actual, you know, diabetic ulcers and that type of thing. I could look to see if there's any other more specific data, but I'm not aware of it. It's mostly wounds and others. All right, well, remember, I have my cards back there, so again, you know, anything that comes up, you know, our role in medical affairs is really just to help go through the scientific information.